Your understanding.
Yeah. Are we set, Steph?
Okay, we are recording. Thank you
Okay,
so
so
much.
we apologize. We have Megan Jones-Bell here today from Google, and we will start our recording now. So sorry we missed those first couple minutes, and thanks, Megan. We will leave you be now.
All right, sounds good. So, just to ground to ground our conversation, I think it's helpful to start with some of this data showing that people really turn to the internet first when they're looking for health information, including mental health information. And on Google products, we have hundreds of millions of searches every day with people asking health-related questions. When we look at mental health specifically, just as an example data point, we have 25 billion views of mental health content annually on YouTube. So you can imagine you just really adding that up, even over the last 4 years, it's 100 billion views of mental health content. So just extraordinary demand and desirability for health information and mental health information. You can see the chart on the right. It's plotting searches over time, starting in 20 years ago to today, and just shows this real exponential increase in people looking for help for mental health on Google search. Moving on, let me get this going. We all tend to have a slightly different thing in mind when we think about mental health. And so the definition that we use to guide our work at Google is the World Health Organization definition, which describes mental health as a state of well-being in which an individual realizes his, her, or their own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to contribute to his, her, or their own community. I like this definition because of its emphasis on mental health as something we all have and as a state of well-being. When we apply that in the context of our policy or product development efforts, what we like to use is this dual continuum model because it's a nice blend of the World Health Organization definition and a conventional medical model with this juxtaposition of well-being as well as the presence or absence of a disorder and the disorder severity. So when we take this dual continuum model, which comes out of the clinical psychology research literature, we believe that there's a really important role for Google products to play across somebody's mental health journey. And also realizing that for many people, this journey is not linear. It's not always a linear progression across, risk to low acuity to high acuity. And particularly for young people, they can go from the absence of any warning signs to a pretty acute state of risk quite quickly. So our approach has been anchored by across Google products, and I have some examples of here from our information platforms, YouTube and Google Search. But we really have tried to elevate authoritative health information because we're really an information company by background. It's one of our biggest strengths, and it's what people come to our products for help with. They're turning to us for information. We didn't think that we should be the arbiters of defining what authoritative health information means. And so we asked the National Academy of Medicine a couple of years ago to convene a group of experts and define what an authoritative health content source is. So who are sources of health information that are evidence-based, convey information that's based on medical consensus. And then we asked them to collaborate with the World Health Organization and the Council of Medical Specialties to help internationalize that. And so we have this multi-phase approach to defining. It's published in Lancet if you're interested. But importantly, we did that external engagement work, but we also built a product around it and pulled it into features across search and YouTube. What that let us do was build what we call a corpus. It's essentially a collection of videos that are have are labeled as being from an authoritative source. The feature that we built in YouTube is called From Health Sources. It's essentially a carousel of videos that's shown to somebody first. So when you're looking for mental health information, the first thing that you're going to see is From Health Sources, and it will show you videos that come from these approved health sources. And on the watch screen, so where you're actually watching the individual video, there's this additional badging that you can see. It's highlighted here. It says from a channel with a licensed health professional. And so that visual cue is also a helpful intervention in and of itself, because it's prompting somebody to reflect on, where is my information coming from? And so, as you can imagine, these are all approaches that help elevate the quality of information that we're surfacing. And respectively on search, we have a longstanding feature that we have collaborative external expert organizations like NHS, World Health Organization, Mayo Clinic, NAMI, others, to surface information about health conditions, including mental health conditions. You see this, it's called, this example is for anorexia, and this is called a knowledge panel. So this is where you see an overview, common symptoms, treatments, specialists, and ways to get help. And then in some of our search features, these are things that we build. They're algorithmic. They're above the blue links. So you see these kind of 10 blue links on most search results pages. But this people also ask feature, which we call related questions, are also algorithmically elevating information from high quality websites. And so that's the way we elevate quality information on search. But we know that people often, that authoritative information is incredibly important. And for somebody who's living with or experiencing a mental health disorder, they often want to hear from somebody who they can relate to, who's walked a mile in their shoes. They want to feel less alone with what they're going through. And so hearing from other people's experiences can be incredibly valuable and important. So right underneath that health sources shelf, the next thing that you'd see on YouTube is a personal stories shelf for certain mental health conditions where we believe that, and where there's evidence that personal stories can be helpful to somebody's recovery journey. And then on Google search for suicide-related queries, we also, in videos, are surfacing authoritative sources that have recovery videos or that promote suicide prevention. In this category of early detection and intervention, something that we've had for several years in the US in English, but recently translated in the US to Spanish and are launching in multiple languages in multiple countries right now, are clinically validated self-assessments that for anxiety, depression, postpartum depression, and post-traumatic stress disorder. These instruments commonly used in clinical practice and commonly used by, Ellen and Denise and others at WashU in population level interventions and research, help direct people to country level resources. In the case of US resources, they direct to NAMI and the findsupport.gov resources, as well as the National Suicide Prevention Lifeline. We also, at more of an individual level in this kind of preventative space, leverage our devices portfolio. So we have the Pixel Watch. You see the Pixel Watch 2 and the Fitbit app. We also have Fitbit trackers. We have Nest. We have the Pixel phones. All of those are tools that we use to help people manage stress, promote restful sleep, promote healthy behaviors, all that are part of, practicing healthy routines and behaviors that help you manage your mental health. And one of the features that we recently launched, we just launched our Pixel Watch 2. This is the one you see here. And something that we had on a prior Fitbit Sense product, but it's still relatively new to the industry, is a continuous electrodermal activity sensor. It's essentially a sensor that measures your kind of skin conductance and essentially sweat, but also our algorithm combines that with heart rate variability, heart rate, and a few other variables to help give you notifications of stress moments throughout the day. It's not telling you in the moment when you're stressed, because we didn't think that would be very helpful, but essentially over the course of the day is helping you reflect on the times where you were more activated, and then helps you link into some journaling activities and this check-in that helps you become more aware of your mood throughout the day. And we know this is associated with sleep, which is one of those kind of the relationship between sleep and stress is incredibly important. And so we have a number of interventions and resources in our devices portfolio. And then as we move across, I'm just moving across this continuum into crisis care and support. For many years, Google has surfaced national crisis hotline information at the top of the search results page in Google search, as well as in the YouTube product, directing people, for example, in the US to 988. One of the things that we also launched in the last, last 6 months is what you see on the right-hand side of the screen, which is what we call coping module. It says connect with people you trust. What we heard in our work with other organizations, experts, and people with lived experience suggested that, for people, not everyone is ready to contact a crisis hotline, or they want to actually connect with somebody that they know, but they can't find the right words, or there's barriers to reaching out for help. And so we asked the International Association for Suicide Prevention and their lived experience panel and clinical experts to write these text fields. So you see these different boxes. One says check-in. There's a couple of different categories to try to capture different types of experiences. If you click on that from your mobile device, it opens a text message that you can send to somebody that you trust. And this is essentially a way of helping people find the words to ask for help in moments of crisis. In the zone of suicide prevention and crisis support, we've also engaged with a number of external organizations to try to help them build their capacity, because we can use Google's megaphone of, encouraging people to reach out to 988, but we need to have capacity on the other end. And so one of the things that we've done now with the Trevor Project and with Reflex AI, building a product that we've just made an announcement about yesterday called Home Team, which is focused on supporting veteran suicide prevention, is we've built these conversation simulators using large language models to help simulate crisis conversations, essentially so that a staff person at one of these nonprofits doesn't have to pretend to be somebody in crisis over and over and over again, which you can imagine doesn't scale very well and also isn't very realistic. And so this is essentially automating volunteer training so that they can scale capacity to meet this incredible demand for crisis support that exists. We also have policies. I've talked a lot about our product features, but importantly for Google products is our internal policies that protect users' mental health, well-being, and safety. And there are many of these. I've just given you a couple of examples here. So this includes things like our ranking algorithms of how we classify harmful websites as low quality. Sites that we deem low quality are returned lower in search results pages. Our features, so some of the things I talked to you about, our knowledge panels or related questions. We have policies that disallow content that could facilitate harm or promote suicide and self-harm behavior. And ad policies. So we have a number of ads policies related to protecting mental health, protecting young people, and content policies that I'll get into a bit more detail on in a moment, which is right now. I wanted to give you a just kind of case study of how when we take some of these product features and policies together, we can take a bigger step forward, because essentially from my team's perspective, working across products, working with trust and safety, and our partnerships team, our creator community, there are multiple levers that we can use to make a bigger impact on particular conditions. And so eating disorders and disordered eating is a great example of how we've pulled multiple things together in the service of trying to move in a more preventative direction. So in the spring, we announced this kind of bundle of things. One piece of it is a disordered eating policy. So we worked with eating disorder experts in many countries, including eating disorder prevention experts, to revise and update our disordered eating policy. We, for many years, have had one that disallowed content on the YouTube platform that promoted eating disorders or glorified eating disorders. But we wanted to move it into more of a prevention zone. And so we now prohibit content on YouTube about eating disorders that features imitable behaviors. And what I mean by that is videos like what I eat in a day or thinspiration content, videos that essentially show behaviors that, if you imagine somebody at risk for eating disorders doing those behaviors, could exacerbate their risk for the onset and progression of an eating disorder. We also, as part of that, remove and prohibit content related to weight-based bullying, which is a known risk factor for eating disorders. Then, because the personal stories and recovery stories about eating disorders, they're incredibly valuable when they're done responsibly, but we have an issue, and that we're actively working with the creator community on, that both some of these recovery stories and some of the educational, documentary, scientific, or artistic content that is about eating disorders may actually exacerbate risk. It may have visual images of emaciated bodies. It may be triggering in some ways. It may include too many numbers or specific behaviors. And so what we do in those categories is age restrict it. So you need to be logged in and have a verified account to be able, as an adult, to be able to view that type of content. We also added a crisis resource panel for eating disorders in several countries, and then collaborated with a number of organizations, including the National Eating Disorders Association, to create more content that's helpful in the area of eating disorders. We, in the last last week and then one a couple of weeks ago, have made a series of additional announcements about work that we've been doing related to kids, teens, and families across our products, and really specifically on the YouTube platform. So I wanted to share some of those highlights with you. But first, just to orient you to, this is how we think about kids and families at YouTube across our products. Our approach is built to protect, meaning we have default protections. We work with child safety experts, and we have industry-leading child safety policies, as well as educational programs that are implemented in schools to protect kids and teens from online harm and promote data privacy. The next pillar of our strategy is to respect kids and teens, to respect and understand their unique rights to information, and offer developmentally appropriate choice and flexibility that empowers kids, but also respects every family has a different relationship with technology. And then the third pillar is to empower kids and create high quality, delightful experiences that support their safe and helpful online exploration. We also, across products and I've just pulled a couple of examples here, have had long-standing digital well-being features, essentially tools to manage your time online. And in the case of under 18-year-olds, most of these are turned on by default. So take a break reminders on YouTube are turned on by default. Bedtime reminders are turned on by default, and many other things. We also try to elevate, as you can see, this is a theme across our efforts, is trying to elevate higher quality, helpful information We also elevate higher quality and helpful apps on Google Play to support kids' well-being. And we have a program on Google Play called Teacher Approved, which means that our extensive network of teachers around the world review every version of an app and every update of an app. And so to be eligible for an app to be included in our Teacher Approved app section, it really has high standards for quality and developmental appropriateness. And teachers are actually reviewing every single version of it. So it's, I think, incredible program, and mental health and well-being is a subcomponent of that program. We recently announced updated youth principles that guide our work and are at the core of our work to create a safer and more enriching environment on YouTube specifically. The piece I wanted to highlight here is that we have made this public declaration that the privacy, safety, mental health, and well-being of children and teens require special protections online. There are many other important aspects. Each of these pillars is incredibly important, but I wanted to share some examples of things that we have just done and announced in the service of that, and you can expect a lot more in the coming months and years. So one, we have extensive parental controls and actually have an entirely separate product, YouTube Kids, that is made just for kids that has an even higher standard. For teens, we have, and younger adolescents, we have supervised experiences, which is the parental controlled version of the main YouTube experience that is optimized for younger adolescents and teenagers. And then we have this, we've tried to raise the baseline across the main YouTube experience as well. We work with our Youth and Families Advisory Committee that has experts in children's media, child development, mental health, and many other backgrounds. So one, in the YouTube Kids app specifically, we also elevate high quality content. That's what you see on the left. And then in supervised experiences in the main YouTube app, we are actively funding and working with organizations like the Academy of Pediatrics, Child Mind Institute, Jed Foundation, Trevor Project to help them create more high quality content that's engaging for kids and families on our products. One of the things that we just announced is that we've changed our recommendations algorithm so that we are now limiting repeated recommendations. So this is YouTube's Watch Next. It's essentially the algorithm that recommends the next videos to watch. So now we are limiting exposure, repeated exposure to videos that could be harmful over time. They're not policy violating in a single video, meaning that we don't think watching it one time is harmful. It doesn't violate our policies. But if you were to watch 50 of them, it could cause a negative impact on mental health and well-being. We focused that on comparison of physical features and idealization of some types of bodies over others. And so this is this general category of social comparisons, as well as, these specific things about fitness level, body weight. And then we've also limited exposure to social aggression. So this is non-physical contact, fights or intimidation or depictions of bullying in videos. We've also made our take a break and bedtime reminders turned on by default and have this full screen takeover approach, which is what you see on the far right, coming in early next year. So essentially, the more our user interface disrupts the flow of your viewership, the more likely kids are to take a break and engage with that reminder. And so we've made it a bolder reminder to try to help with that. Similarly, our crisis resource panels include a new pause page. So what you see on the left is what we've had. What we're moving to is what's on the right, where you can see, instead of actually seeing these video thumbnails, you now see just this takeover page that you have to either click and contact a hotline, engage with a self-help content, or this tiny little blue link down here is show me the video anyway. And so we've really tried to encourage the default behavior to be help seeking and promotion of well-being. And then to guide our work in adapting some of our mental health features for younger populations, we've asked the World Health Organization to convene experts to help define new mental health quality principles that are developmentally appropriate. And so many of our quality principles are actually based on adults or based on risk. And we really want to think about and understand what are unique considerations for youth that help us connect kind of risk or prevention framework with developmental appropriateness and helpfulness. This will be published so that other platforms can use this approach as well. And then we've also announced recently a partnership with Common Sense Networks to help produce educational resources for parents and teens on how to responsibly create videos online, so that we are promoting, for those teens and families that are creators to help them be more responsible. And any teen creators videos are set to the most private setting by default, and have been for quite some time. So I will stop there. And I think Ellen has some questions.
Yes.
And welcome all of yours.
Megan. That was fantastic. Really exciting to, even hear all these new things that are just came out. So congratulations on so much amazing work at Google. And so, yeah, I have a few, bigger questions that maybe we can tackle. And then, I see, Catherine, you've put one question in the chat. And if others have any topics they want us to be sure to get to, feel free to put things in the chat and we'll open it up in just a little bit. But maybe to start off, Megan, one question, I heard some interesting, you were talking about the simulations that you're using to train the crisis workers and AI. And I think in general, AI is a growing interest at our own institution and of course, across the globe and across sectors. And I wonder if you can tell us a little bit about whatever you can share in terms of the future of, AI at Google and how that might be used for detection of mental health problems, maybe actually prevent, using generative AI to offer preventive or intervention tools for folks with mental health concerns. So would love, anything you can share with us about that.
Absolutely. So our approach to AI across the company is, we talk about as being bold and responsible. We really believe that the future of healthcare and mental health will include AI, that it's going to be an accelerant and a tool. It's not going to be a replacement or substitute, but that, increasingly we will be integrating that technology into approaches, and that it's important for us to push that forward. I'll kind of paint the picture of when you think about Google, what we want to build are either at a platform level or tools that developers or organizations can use to guide and enable their work. And so things I don't expect Google to do is build a first-party therapist chatbot, right? Or for Google to be, diagnosing mental health conditions via AI, because that's not really the relationship and role we want to play. What I can see us doing is more building the capabilities, these foundational generalizable capabilities that help enable other more appropriately equipped institutions and organizations to play that role and build on top of that. I'll give you an example of what I mean. So we've published and built a model called MedPalm, which is trained on, it's a generative AI model that's been exclusively trained on medical licensing exam questions. And so you can think about it as like a really smart resident. And so done that in multiple languages, and shown it can pass medical licensing exam tests. better than clinicians, essentially. And so one way that, so what we do with that, because we think that kind of model is going to be more appropriate for healthcare use cases than a model like Bard, for example, which is trained on the internet. And so Google has made and is continuing to create and improve a range of different generative AI models, because every model has different strengths and weaknesses. And so that's what we want to build, as well as put those things into cloud in a way that enables a if your team at WashU wanted to build something, you could take MedPalm and use it. An example of what we've done, and you'll see some of this work published. We have one paper on archives right now from some of the folks on my team, showing that we used MedPalm to predict psychiatric diagnoses with very high levels of accuracy. So that's an archive right now. We're not necessarily going to put that into a product. But what we do is we build something like MedPalm, and then we might publish some papers that show what you might do with it as a way of trying to encourage the external partners that are using Google Cloud to take that and build on top of it. So that's really the way that I see AI. What I didn't talk about when I was talking about a crisis approach is actually one of the first places where Google chose to apply generative AI in a Google product was on search, and was building our classifier to detect and understand personal crisis queries related to suicide and domestic violence, because our accuracy of understanding the nuances of human language around suicide and domestic violence queries was this huge leap forward in accuracy when we used this multitask unified model that can, read, understand, and generate language. And so it was actually in the first 3 use cases several years ago, before anybody was talking about AI. So we kind of invisibly put that in there because it was such a big improvement in our ability to detect suicide queries, which lets us then show a national hotline information, right? And suppress other features on the page so that there's a simpler call to action for when somebody's in crisis. They don't want to see all the blue links and ads and other things, right? We want to really simplify the design of the page and make that hotline more prominent. So I'd say, one, you can continue to see AI show up in these invisible ways that make our products safer and more helpful from a mental health and well-being perspective. A lot of that is invisible, and it's just like things just will work better. And that's really the main thing. The other piece would be our enterprise focus of what do we need to build that gives you the tools that you need to apply AI, have models that are fit for purpose for what you want to do, and have the analytics and cloud compute capabilities. So, and that's what we've done. We've done it for mental health. We're doing it for a variety of other topics as well.
Yeah, that's fantastic. No, thanks for shedding light on that. And I guess, Megan, too, maybe before we open it up, what do you see from your vantage point, at Google and, kind of being such a touch point for basically everyone and, having such an important role in mental health? Like, what is the most important research, that we, thinking about us here as mainly academics on this call, what do you see as some of the main research that we should be doing to help, kind of fuel this work and make a big impact? What do you think is needed?
I love the question. And I can tell you what, because much of what my team works on right now, before we take any decision or any action, we're doing literature reviews. We're, turning those out on like a daily basis. but there is nothing to pull from in some areas right now. And so I'll say the two things that are really top of mind for me, where one, we need a different approach to the research because it needs to be much faster. It needs to be on archive, available, fast, not along RCT, right? So the methods need to change, and we've been directly working with NIMH and Wellcome to try to help them understand how that, approach to research needs to be different in order to have the impact we need to have from a public health level faster. What I'm specifically thinking of is we know the kind of harm that social media and media products lead to. We know some of the subpopulations that are most vulnerable. What we don't know is what kinds of alternatives would work better. So beyond just prohibiting use of these products, which has a lot of other secondary harm consequences associated with it and just isn't practical, right? Like kids with learning disabilities use YouTube to better understand information to help them with their homework, right? We don't want to block kids from the helpfulness of information platforms. And we want to respect their rights in a developmentally appropriate way. But we actually need to have evidence-informed strategies of how we capture the benefits of these platforms most, how we can deploy content and information in ways that actually work. And so what you see right now is an industry that's under pressure to evolve and put protections in place. But what we don't have are evidence-informed ways to do that outside of a couple of cases, right? So really, and you can prototype that and test it easily. And so there's certain questions that are more appropriate for external, like it's not appropriate for us to go test a product feature on a clinical population or do even user research on that. We need that literature to exist, there to be consensus around it, and then we can pull it in and build policies and products around it. So that really being, and I'd say like those kind of things immediately could be put into products, ours as well as others. The other area is around these open chatbots and their effect on youth mental health, because what's very much on my mind and what we're basically having to take a hypothesis-informed approach to is what elements of some of these open chatbots are beneficial or harmful to youth mental health specifically. And so if you look at the landscape of some of these openly available products right now, we don't really know their specific effect that product design decisions or the algorithmic decisions will have on kids and teens. And we need to quickly understand that, because we have a commitment to building products in a responsible way. We're working really closely with experts to inform our approach, but there is no evidence because these things are completely novel. And so that's what I mean by different approach to research and this tighter relationship between the research community and tech companies, right? Which means the timeline of research needs to shift.
Yep. Yeah. No, that's terrific. Well, two quick, maybe not quick, probably follow-up questions, but one, I think many on this call, these ideas resonate. One, is there anything that you can share in terms of any, promising conversations with funders like NIMH or Wellcome? And then I guess two, in terms of what you said about the closer relationship with, tech and industry, anything further you can enlighten us on about, partnering with Google, or how we, can best position our research to help, directly inform your work?
Absolutely. So one, there are, it is typically one of the things, we've got a lot of tools in Google Cloud that are incredibly relevant to big data set research. But in order for a researcher to take advantage of those, your university has to be on GCP, on our Google Cloud, right? So if you're not on Google Cloud as an individual researcher, it's going to be really hard for you to make that actually happen. But it's important for you to know that there's a number of tools. It's how you tap into our Gen AI models and the analytic capability, the compute credits. So one that would be that's one piece. There's a tool that anybody can use, and this doesn't matter about whether you're on cloud or not, or is our Google Takeout. And so by law, tech companies have to provide individuals with the ability to take out your information and move it to a different platform. So an example would be taking photos from Google Photos and putting them into your iCloud and Apple Photos. So what we have built is something called Takeout, and there are a number of researchers who have already used this in the context of mental health research, where you can think about this as social media data shows you what somebody is putting out into the world, but your Google search or what videos you've watched on YouTube is more of the inside story, right? It's you're not choosing to share that. It's some of your most private information. And so that is available. And what researchers have done today is they've basically built consent flows that where they get consent from individual participants to get access to their Google Takeout data. The participant downloads it, puts it in a cloud storage place that the researcher manages. And so it's a bit more manual. We are building an API to enable that, it to be far easier, which is designed really with make it better for users, but also make it easier for researchers to use that. As much as people think I have the ability to use all your Google data, I can't. So there are questions that are really important questions to ask, and stories that this data tells that really would help advance our understanding and could inform product features. But I need that research to exist externally that then we can use internally. So Takeout would be one of the things. The Gordon and Betty Moore Foundation is currently accepting, is giving out small kind of proof of concept grants, like 75 to 100K. So you can reach out to Gordon and Betty Moore Foundation. They're giving grants for Takeout right now. And I also just did a session with Josh Gordon and Miranda Wolpert at NIMH and welcome to help them understand this. And so, and Pat Ariane, who just joined NIMH, has done much of this research herself. So I think we've done a bunch of sessions with both of those funders to help them understand Takeout, LLM data, and kind of approaches to research that would create a better flywheel between the research community and product development. So they're and both have funding calls come this year or in early next year that are relevant for this.
Oh, fantastic. Well, this has, been amazing, Megan. And I see, Allison, maybe you have a burning question. If it's okay, maybe we'll start to open it up to the group in our last 10 or so minutes. But yeah, Allison, did you have something related you wanted to ask or a different question?
Yes, I think it's a good piggyback along the lines of like partnerships, whether it be with industry or academic centers. And so this is a little unrelated to mental health, but maybe more on the wearable sensor side of things, which is where my research interest is at. And so I know that, Google recently acquired Fitbit, and you mentioned that Google has come out with some new devices. And so Catherine Lang and I, who's also on this call, are working on a project where we're trying to integrate sensor technology into our healthcare system and electronic health record, because we recognize that these tools can be really powerful for measuring things outside of the clinic that we only see in a short snapshot during our in-clinic time. So I'm just wondering if you could comment on, if Google has had any partnerships with academic medical centers to actually test some of these technologies in a healthcare setting, or if that's a direction that they're interested or open to building on.
We do. Let me just I'll put a link in. We work extensively with healthcare organizations to integrate our wearable sensor data We've done that in NHS, in multiple trusts and several health systems in India, around cardiac rehab. We have a approach via Google Cloud called Device Connect, which is what can pull Fitbit, including Pixel, which is just kind of ignore it, it's just branding. Basically, our wearable devices data into Google Cloud. There are other APIs that we have available, and I can send those over. But we have Health Connect, which was called Wear OS. It's essentially for Android devices. So we have a tool that pulls all of our sensor data in there. If there's specific sensor data that you don't see in any of these publicly available APIs from Google, then you can always reach out to our team and our research team to propose something and try to get access for research purposes. Or if it's for a health system, it's for a clinical implementation. Mm-hmm. We do that for partnerships as well.
Great, thank you so much.
Mm-hmm.
Great, thanks for the question. And Catherine, I don't know if you want me to a sort of related question, but I know you and Allison work so much in this sensor space. Would you like to ask your question?
Yeah, I'm just curious about how whether Google tests them themselves, or who do they go out to test the different algorithms where you transfer the data from the actual sensors in the device into the information that you're displaying, and who are you testing them on? How big are those samples? I'm very curious about, are they general population samples, in which case we need to think about how they might generalize to patients that have specific conditions that don't represent the general population. Be that it's a great steps, or stress, or heart rate variability, or whatever it is.
I think we have like over 100 studies right now going on sensor. So we do a ton of research. It's all in collab. We have some labs internally, like brick and mortar activity labs. Whether we're collaborating and whether we're doing it internally or externally is a question of the phase of the research. So some of the really early exploratory work we do ourselves in some of our labs. As we move into more clinical validation, then we're using clinical research organizations or academic research partners to validate our algorithms. In some cases where we want to make claims for a particular population, it will be more narrowly defined. In most cases, they need to be general populate, right? These are general population products. And so we need to test them on, but in some of our studies, we need to make sure that there's a certain representation so for our, probably the best example is our irregular rhythm notification. So our features to detect atrial fibrillation. We need to make sure that there's going to be a sufficient sample size of people who will have AFib. Otherwise, we're not really testing it. So depending on what it is, the studies are designed differently. We also have some of these features, like our AFib features, are regulated and have to have regulatory clearance in all of the countries where they're available. And so, then you're talking about going through the full kind of life cycle FDA, from a pilot to pivotal trial kind of criteria. But I'd say the rule of thumb is a lot of external academic collaboration. And we have certain relationships with universities around the world when we do a lot of research on and validation work. And that's something that, my team does a lot of that for our wearables portfolio across the range of features. So if you're interested in more about that, Ellen can give you my email address.
Yeah, that's great. Thank you so much. What a great question. I see one other really interesting one in the chat that I'd like to raise from Anna, who asks about how you all deal with controversial mental health topics. So, things like transgender care for children or abortion information for teens. What can you tell us about that, Megan?
Yeah, we have So there's a couple things. One, we have a tool that our health team has built for our trust and safety enforcement agents that helps them, and we have it on 24-hour on call where someone on our team can actually be tagged in to weigh in. We base things on medical consensus. And so where there is medical consensus that something is safe, right, like COVID is a great example. So there were, as we all know, many different alternative things recommended that we would take down, remove videos about, would prohibit ads about. So anything that was promoting information about approaches or practices that could cause harm or were not based on scientific and medical consensus. So that's one thing, because we need to do it at a framework level. We also have this a reason why we have a clinical and health team at Google is to provide that. The other thing is in areas where there's not consensus, we've got a new tool on Google search. It's called Perspectives. And it essentially is helping you see that there's mixed evidence or there's mixed opinions, and some people think this and some people think that. And so it's in some of these areas that are emerging. They're not, we're not talking about misinformation, right? We're not talking about using, leaks to cure COVID. There's a lot of random, it's more, this is emerging, and like Alzheimer's drugs would be a good example of this, right? Like, is this helpful? Is this not helpful? Even the FDA committees can't agree. So where there's legitimate lack of medical consensus, we're surfacing multiple opinions just to help people understand this isn't a binary. This is actually kind of emerging. And so that's a way that we're trying to still within a no misinformation, but where there's a lack of consensus. And so that's essentially, and I'd say on the transgender piece, I mean, that's why we're really pushing hard to not prohibit the use of our products in developmentally safe ways for teens, because we want to promote the right to information. And we know that is at risk in certain locations.
Yeah. That's great. That's really helpful. Well, I see we have 2 minutes left. Does anyone else have one more rather quick question to raise? And if not, that's okay. Well, Megan, I want to be respectful of your time, and I know we're almost out of it, but this has been really terrific. I feel like I know I learned a lot, and I think have some good ideas for the type of research we can be thinking about from where we stand, and definitely am interested too in these ongoing conversations with funders, as you discuss as well. So we'll have to continue talking about that, but I definitely just want to thank you deeply from all of us for taking the time to join. And I see Denise has chimed in with her thanks as well, another old colleague of Megan. So we're so happy to have you here and learn more about the really exciting work you're doing. So thank you for taking the time today.
Well, thanks so much. It's been great to reconnect. Spent so many years working so closely with Ellen, Denise, and others at WashU. It's great to come full circle.
Yes, it's been so nice. So thank you, Megan. We really, really appreciate it. And thanks everybody for being here. And you can look out for more news from the MHRC on our next seminars and events. So thank you all.